Hey, everybody. I'm Lauren Swagger. I'm a psychiatrist and a child and adolescent psychiatrist. And today we're going to talk about antipsychotic medications. And I'm going to approach this from a largely clinical perspective, but I'm really grateful to have my two pharmacists on here to help add some rich detail to some of this. You'll hear me say at one point, especially when we get to long-acting injectables, that I can never remember how to dose it. So I always reach out to a pharmacist when I get to that point. So please jump in. And as always, I love questions, chat them in, just come off mute, interrupt me. If you don't interrupt me, I feel strange. So I like the interruption. So I am going to share my screen, and I also have an attachment that will go with this that we'll send out that's like a quick med handout too, that can help kind of be a quick reference for some of the things. I'm not sure I'll get to show it to you during the course of this, but some of the dosing and some of the side effects profile pages will all be in that quick reference handout that we'll send out afterwards, as well as the slides. All right, so let me get this shared with you. Can you guys see that?
Yes, we can.
I also have tried to be a little more head tech this time, and I have some like live action clips I want to play for you, but I do not know if they'll work. So you're going to be part of my educational teaching IT experiment today. See if I learned anything. All right, so we're going to talk about the basic categories of antipsychotic medication. We're going to talk about the reasons you might use clinically an antipsychotic medication for adults or children. And then a lot of antipsychotics are really understanding side effect monitoring, and that is a substantial piece actually of continuous care in the outpatient setting, because while these medicines are incredibly helpful for many clinical things, once people are stabilized, the monitoring really never stops. And so it is accurate that about half of this presentation is understanding side effects, because they really can occur at any time and may warrant a change in presentation. And so they tend, especially for children, to be very highly monitored as well, given some of the complications. And so I want people to know what to look for. And also, if you see a side effect developing or emerging in care, especially if you're a therapist or a care provider, it's really important to realize that it might be related to the antipsychotic, and it's important we get some follow-up if that becomes a question. So antipsychotic medications are typically divided into these older first-generation antipsychotics that used to be called neuroleptics or typical antipsychotics, and newer agents that are called atypical or second-generational antipsychotics. And there's some major differences in how the medications work in terms of what receptors they might hit, how they exert their antipsychotic actions, and really major differences in the profiles of the side effects. And so this is not totally accurate, but traditionally a lot of the motor side effects like tardive dyskinesia or dystonia were likely more prominent in first generation. The second generation atypicals antipsychotics have really shown more pronounced issues, sometimes with weight gain and metabolic side effects. And so while they all may exert similar antipsychotic actions or mood actions, there really can be quite differences. And we're going to talk about, depending on looking at medicines, how one might be a choice versus another when you take into consideration some of the other medical problems or concerns in your patient. And clozapine is kind of in a category of its own. I'm not going to talk about clozapine during this conversation really, but I really think clozapine is really underutilized, especially in patients with psychotic disorders and schizophrenia. It is really the gold standard for refractory psychosis in patients with schizophrenia. It has a lot of monitoring that goes with it, but it's truly a life-saving medication. And even people that, up to 50% of people that have failed traditional first gen or second generation medications really can have substantial improvement with clozapine. And I'm a believer in clozapine. But it is you have to register as a provider, you have to register as a pharmacy. It's a little harder to get. Patients have to sign up and be willing to get frequent lab draws starting out weekly when they start. It's complicated, but I never want to forget clozapine, and I'm not going to go into clozapine, but I want people to know that if you have tried repetitive antipsychotic medication without success, please never forget that clozapine is something to consider. And it really is the one that has shown the most improvement in refractory positive symptoms, as well as reducing some of the negative symptoms that are also challenging. So never forget clozapine, but I'm not going to talk about it much beyond today. Here are some of the names of the medications that fall into the categories that you'll recognize. Haloperidol or Haldol is probably the most common. We still see a fair amount of chlorpromazine or thorazine being used. Most of the first generations vary to some degree in how, and even they are categorized in different categories based on how intensely they bind dopamine. But these medications are used. I've highlighted both Haldol and Orap because actually outside of their antipsychosis use, these actually are FDA approved for Tourette's and tic disorders. And they are rarely used for that purpose. But I do want you to know they exist. And some of that is because of the risk, some of the long-term movement effects, and people sometimes will use other things before they will use the FDA approved ones for those disorders. The second generation atypical antipsychotics are probably ones you see ads for, especially when at the bottom are newer medications that you'll often see a lot of advertising for. Many of the others have come forth in the last couple of decades, and you'll see both their brand and trade names here. I'm going to talk about clinical uses here in a minute, but I've highlighted on this slide the ones that have pediatric approvals. So Risperdal and Abilify, on top of their adult approvals for those things, are also indicated for childhood autism, behavioral disruption, bipolar disorder, and schizophrenia. And then Zyprexa, Seroquel, Safras, and Invega, and Latuda, the trade names of those medications actually have pediatric approval for bipolar disorder and schizophrenia as well. This is where I always phone my pharmacy friends because I do not do this enough to get really good at it. But if you are seeing people with thought disorders on a regular basis or involved in a inpatient psychiatric facility that may experience recurrent admissions for psychosis or state hospitals, this is really something I also have, much like clozapine, a really important appreciation for. So it is challenging to remember to take medication every day. It is challenging in terms of relapse, but it's also challenging in terms of the dysfunction that can occur when people become psychotic. And there is substantial evidence for really improving healthcare outcomes in folks with schizophrenia and even bipolar disorder to some degree by the use of long-acting injectables. These medications are usually taken every 2 weeks to every 4 weeks, and some have even been extending out a little further. Most of the time, people are stabilized on oral doses and then transitioned over to these injectables, and then they can just schedule, an appointment every few weeks. But it's been really shown to be helpful at reducing readmissions, really improving quality of life and relapse for a lot of people. In fact, I recently took a course at the APA, and for years we talked about needing to fail oral trials to get long-acting injectables. They were actually making a case that long-acting injectables really clinically have utility, even in first episode psychosis now with good outcomes, and really encouraging them to be thought of not just as a treatment of last resort, but really maybe the preference in a lot of ways, because people do tend to like them if sold correctly. A lot of people are afraid to offer injections to people, but a lot of patients, when you really talk to them, would much prefer a weekly or a monthly injection and build it into their routine than have to remember every day. And so there's been a turn in clinically how people are considering long-acting injectables and thinking about them earlier too. And so these are some of the current ones that are out there.
Swagger, out of curiosity, were they recommending to still trial an oral for tolerability before starting?
Yeah, I think that was yes. And I think they were just sort of suggesting that you didn't have to wait for them to fail the oral or stop the oral. But yes, from tolerability, that was still in place. But I was kind of surprised. That was the first time I'd heard that, if you can really offer it out the gate. I think on the insurance end, that's still something maybe they haven't updated, because they do tend to require some more price to them. But from a cost savings perspective, even that has good data. But yes, so it would be getting up to an oral dose to have some success, because you want to demonstrate that it has efficacy, I think, and tolerability in terms of side effects before you transition. And that is the downside with the long acting. It will hang around a long time. So if someone does have a side effect, it's a little more challenging, but it was interesting to see that. I don't know if anyone else had heard that before, but that was very new information to me. This is a really messy chart. I'll show you this chart again when we talk about side effects. I'm also, this chart is also replicated in a little bit of a different way on the handout we'll include at the end. But I did want to sort of orient you to this chart a little bit, because I think when you think about an antipsychotic, when you're using it clinically, I mean, all of them will have some benefit on mood and psychosis. Sometimes we are tailoring the medication we pick to the side effects we either want or don't want, or past tolerability. And so when you know that someone has struggled with certain side effects before, this is where you might pull out this and really try to understand maybe what it was about the medication that was a challenge. And so at the top of this, from this chlorpromazine upward, are these first generation antipsychotics. Those are those older typical antipsychotics. And then all of these on the bottom are our newer second generation. And we have their brand name. They're giving you a traditional dose range for the FDA approvals of these medications. This is this column right here. Can you guys see the little pointer? Are you able to see the pointer?
Yes, we can.
Okay. This column here is telling you what its FDA indication categories are, whether it has adult or adolescent approval and the age range on that. I'm having trouble seeing at the top here because the slide is so big. But these columns right here, we're going to talk more about. These are kind of related to the side effects and the receptors that they hit. So we will come back to this, but this allows you to kind of compare some of their risks of movement disorders versus orthostasis versus risks of sedation, cardiac side effects. And then there's some notes here that can help you kind of choose. And then I would also say the other thing, especially with newer agents that aren't on this list, is that a lot of times the newer agents are quite expensive. Many of the second generations are now generic, and they are often on the preferred list of many formularies. And so, when patients come in frequently seeing the latest ad for one of the newer ones, that's what they want because they saw the ad. The cost is impressive, several $1,000s sometimes, versus a medication that only costs a couple tens of 10 or 20 bucks. And so it's really important to understand what the patient's options are, because some of the new medications are not on formula and incredibly expensive. And most of the medicines in head-to-head action, while they have differences, have not really shown tremendous efficacy differences, especially in terms of treating psychosis, to warrant choosing the more expensive over a cheaper one if the patient's never tried it. So you often have to be thoughtful about what the patient can afford or what their copay may be of some of those as well. So why do people use antipsychotics? And the reasoning has expanded dramatically over the last couple decades as we've really learned about what these medicines do. Traditionally, they were really thought of as being antipsychotics, treating psychotic disorders, so schizophrenia or psychotic symptoms from other secondary causes. But as time and space and understanding of the medications have occurred, we've seen some evidence-based utilities in other areas. Not all of them have FDA approval, but there is a fair evidence base for them across an array of symptoms. And so one of the things about all antipsychotics that I think is really important is they are actually most all of them, with some exceptions, are anti-manic agents as well. So you can see them being used in people when they're floridly manic, that very high, no sleep, talking a million miles an hour. Most of them will treat mania as well. And sometimes that mania has psychosis as well. When you talk about bipolar disorder, you have to understand what phase of illness the bipolar disorder is in, regarding these medications. And I've given a talk on bipolar disorder before, and we can revisit that, but you really have to appreciate what the current phase of illness is. If a patient has bipolar disorder and is currently depressed, some of these antipsychotics do not have much antidepressant activity, and so you may not choose that medication. Some medicines are just trying to maintain stability. They're not actively manic, they're not depressed, and you're finding a medicine to hold maintenance. And so when you're making decisions about which antipsychotic for bipolar disorder, you'll want to have an understanding of, is this a patient that has recurrent mania psychosis, or is this a patient that has more depressive symptoms? The mania can help guide some of the choices in that regard.
They're always on the lookout to attack. And
both Abilify and Risperdal specifically, but all of the antipsychotics to some degree have shown help with these sort of wild, self-aggressive, tantruming behaviors in autism, and Risperdal and Abilify have approval for that purpose. They are also medications, especially Risperdal, that has shown utility in intellectual disabilities for really severe impulsive aggression or self-injury. The dopamine blockade effects have helped with some of that severe dysregulation, even off-label. All antipsychotics, with some exceptions, can maybe help with tics, and we talked about some of them being actually FDA indicated for that, but a lot of the antipsychotics in second generation are useful after failing alpha agonists like clonidine or guanfacine for tic disorders. They can help in that regard as well. And when we talk about side effects, it is challenging sometimes, and I'll show you some videos to decide if something is a movement side effect or is a tic. When you're using antipsychotics, it can be a tough thing to kind of tease out. Severe impulse control disorders can be utilized. And then one of the newest things that we've seen in the last decade or so, and what some of the new ads going on are, is that some of the antipsychotics, especially those with mixed modulator activity like Rexulti or Abilify, where they have this partial blockade of dopamine but not complete, have been used to help with depression augmentation. So some of these are being used not for bipolar disorder specifically or schizophrenia, but they're actually augmenting antidepressant treatment in select populations as well. So it's a very varied, and if you see a patient and they're on an antipsychotic, don't assume you can tell what their diagnosis is from the antipsychotic. I always ask people what their understanding of the medicine was, especially in some of the off-label uses of these medicines. But they're very varied and may be on them for lots of different reasons. Okay, I promised you that a large part of this would be side effects, and we are quickly moving into that because this becomes the challenge, and side effects are often reasons patients don't want to take the medications. As looking at these medicines as sort of precise medications, or I call them the hammer medicines, where they hit so many things. Antipsychotics are kind of big hammers. They're not super specific in what they target. They can hit a lot of different receptors. They're very, very messy medications. And so many of the side effects are not related directly to the anti-manic or the antipsychotic effects of the medicine per se. It's all the other receptors that get hit. And over the years, people have really tried to make better antipsychotics that still treat psychosis without the side effects. But as a general rule, they're fairly dirty medications still. And it's this dirtiness and the other things they hit that can be really kind of intolerable to patients. And so I spend a lot of time when people are clinically stable, their mood's good, they're not psychotic, just making sure they're tolerating it okay, because some side effects you can manage and make more tolerable for folks. Sometimes you just need to think about changing a medication and having a conversation, because they can become quite overwhelming for some patients. And some of the side effects were cited as reasons patients didn't want to take them. They made them feel bad. And it was like, well, I know this medicine keeps me out of the hospital and I don't hear voices, but I just feel terrible when I take it. And that can be really challenging when you feel better in other ways to keep taking a medicine when that makes you feel bad. So the biggest risk is that, to some degree, most of these medications, especially the ones that are dirtier, that hit histamine receptors or alpha receptors, can have very high risk of sedation. A lot of the lower potency first generations, like the thorazine, can make people incredibly sleepy. Most of the second generations can also make people quite tired, and clozapine, which I did mention again, really can make people tired. They can sleep more, or appear to be sleeping more than they normally would. Anticholinergic effects are also quite impairing. Again, this is usually histaminergic or anticholinergic effects, where these medicines can cause really impairing dry mouth and dental problems for people. It can cause blurry vision. People can feel like they're too hot all the time and they can't really regulate their temperature. And even long-term anticholinergic use can cause this like anticholinergic haze and can almost look like dementia. And there have been reports recently of long-term anticholinergic use sort of worsening dementia diagnoses as people got older. So that can be a challenging thing. Orthostasis is more of an alpha receptor effect, where people will literally feel dizzy when they stand up. They may have orthostatic hypotension symptoms. And if there are other medical problems that contribute to this, this could really be a pretty uncomfortable thing, and something really dangerous in elderly patients, where they might be at risk of falls from that feeling. And there are all sorts of warnings on antipsychotics. I did not list this because it's not FDA approved, but some of the behavioral disturbances in dementia, especially some of the dementia-like symptoms in the elderly that may cause psychotic symptoms, all of these medicines have warnings in elderly patients, actually about increasing morbidity and mortality if on an antipsychotic. And there's a lot of regulation, not just in kids, but in older facilities as well, like nursing homes, about the use of antipsychotics. And it is the anticholinergic and the orthostatic effects that are probably contributing to the mortality effects of those medications. Metabolic syndrome is a serious concern, and really a huge problem, especially, and this is mostly with those newer second generation medications. This is also a serious problem in children. And this is why all the lab work that needs done is really looking for signs of this. This is an idea of insulin resistance. It is rising in our country in general, but right now about 1 in 3 adults already have metabolic syndrome, and using an antipsychotic, that especially those second generation ones, could really add to that burden. So if a patient already has coronary heart disease or diabetes or serious heart conditions, I would think twice about using one of the medicines associated with this, and actually even maybe prefer a first generation medication. And sometimes this is literally a conversation with patients about, what's the biggest side effect that you're worried about in terms of choosing, because some patients may prefer the risk of the movement side effects to the risk of metabolic syndrome or weight gain. And the weight gain effects also are through various receptors, are typically worse with select second generation ones compared to the first generation. I literally have had conversations with patients, if you're most worried about weight gain and metabolic syndrome, we're probably going to pick Haldol. if you're worried about tics and abnormal movements and akathisia, we're going to pick the other one, and really like narrowing it down for them, because there are so many patients that are so worried, especially about weight gain, and to good effect. This is especially a huge concern in children. And sometimes you're starting a medicine to help with something else, and then the weight gain can add substantial other mental health barriers to people, because now they feel overweight, and that can cause almost an entire body dysphoria, self-esteem challenges from the medicine that was trying to treat something. So I think it's really important to be open with people about this, and also be vigilant in the monitoring so that you catch it quickly. Weight gain happens really fast. The metabolic syndromes take a little bit longer, I think, to develop in terms of just monitoring, but the weight gain can be fast. I've had people come back, within a month of that first appointment, putting on 5 pounds, and it can be quite overwhelming. Cardiovascular effects can, again, be a real problem, especially in patients that might have pre-existing disease. A lot of times in kids, we don't see those cardiac effects beforehand, but in older patients, a lot of times it's just helpful to know, especially if there's any rhythm issues or arrhythmias, and many of them do have some suggestions for a baseline EKG. Some medications are known to be far worse at affecting cardiac condition, and Geodon and clozapine and Haldol really do support more close monitoring of those things. Clozapine actually has some specific warnings regarding seizures, but there are other antipsychotics that can lower seizure risks. Thorazine also has a warning on that. And then you can have a fair amount of sexual dysfunction. I should have called this urinary and sexual dysfunction. But the anticholinergic effects can cause priapism or urinary retention. Urinary retention can be very painful for people. Priapism is the maintenance of an erection over 4 hours. That's often painful. And some of the medications will, especially the ones that have high degrees of dopamine blockade, can cause something called high levels of prolactin. And this can really manifest and be a concern with some of the medications in younger people, because if you have elevated prolactin, that can cause a sense of not being able to feel orgasm or sexual effects, but it can actually impact the periods. And you can have women cease having periods because their prolactin has been elevated. And it has also been linked, especially with resveratrol, to gynecomastia, enlarged breasts, and even milk production in men if you get a high prolactin from some of these medications. So those all need kind of monitored. The cardiovascular effects can really require a lot of monitoring. Again, this is one, I think, depending on if you're working with kids versus more older population, can have very different effects, but especially in older patients, there really needs to be strong consideration given to their baseline cardiac function and their rhythm effects, as well as very close monitoring again of that orthostasis, because any pre-existing cardiovascular condition could potentially get worse with antipsychotic treatment. The other major category of monitoring comes with movement disorders. And this falls under the category of extrapyramidal symptoms. And although we don't really know what causes neuroleptic malignant syndrome, a lot of the other ones have been linked to some degree to dopamine and perhaps even serotonin effects of these medications. But these can be movement disorders of very different types. I'm going to show you some pictures of what that looks like as we talk about them. But for those of you that I know work with kids, these are often the things they're asking you to monitor and submit with children on the forms for Medicaid or insurance, because they want to assure that these things are being checked on. Akathisia is a sense of motor restlessness. It can be quite severe, it can be quite mild, but this is an incredibly horrible feeling for patients. They really feel like they can't sit still. They're moving all the time. People get it confused with hyperactivity and ADHD when it's really maybe a medication side effect, and can be really impairing. It worsens with other medications as well, not just antipsychotics. It can worsen with polypharmacy. You can have problems with dystonia or Parkinson's features, and this is the idea. Acute dystonia is almost like a severe muscle spasm. Often happens in the jaws, the eyes, or the neck, where you'll just see very painful posturing of the muscles. I'm going to show you an example of what that looks like, and then you'll get like almost Parkinsonian features. You can get a shuffling gait. You can get like stiffness, or we call it like cogwheeling, that you can kind of feel when you move people's arms. It's like it's ratcheting a little bit from the movement. And then tardive dyskinesia is very, very specifically often linked to antipsychotics. So there are also some other medicines that can cause it. This is really where the long-term concerns from a lot of the older antipsychotics came from. Patients that had been on very big dopamine blocking agents like Haldol for years had started to develop very complex movements. It can be very subtle, from blinking to jaw movement, tongue movements that I'll show you. But as they progressed, they started having even limb movements that were incredibly embarrassing. And so this is really important. And the risk, if you start these medications in childhood, your risk of exposure over time to develop tardive dyskinesia does increase with the degree of years that you're on it, although it really can occur at any point in treatment. Finally, neuroleptic malignant syndrome is a very rare condition, thankfully, but it does occur. It's really scary. It's a medical emergency. And this is the development of a severe fever, what we call vital sign instability, where people can't regulate their autonomic system. Their blood pressure can vary widely from high to low. You can have rapid heart rate. It can impair your breathing, and they get very stiff and rigid and can be almost delirious and confused. This is a medical emergency. They have to go to the ICU, and it's really supportive care and removal of the offending agent, and supporting of their functioning. And it can be lethal if not caught quickly. Again, incredibly rare, but it does happen. And is always something worth being vigilant about. So if you hear of that on one medication, you may have high vigilance of monitoring at reattempting. All right, this is where I'm going to see if my video works. This is an example of akathisia. It's very subtle. Can you hear it too?
I cannot.
I can't hear it either, so maybe.
No, I can't. Yeah.
As you move
Oh,
your
there.
feet or the lips move, for
There.
example, do you have any uncomfortable feeling about it, or just something that just goes on by itself? You feel restless or fidgety or not?
Open my feet, my toes don't. I have to tighten up the muscles in my chest.
Mhm.
This one moves a lot more.
So that was an example of it was very subtle akathisia. You can imagine if you have a kid that you think might have ADHD, if they're sitting there, that can look like fidgeting, I think, from ADHD, which it's not. And many of the folks would pace or want to move. I don't know if you could hear her, but she was asking, like, is the movement bad? No, the movement makes them feel better. It's trying to cease the movement that often becomes painful or difficult with akathisia. And patients describe that very classically when you ask them, when you're moving around, does that feel better or worse? And they'll tell you, I can't sit still. It's uncomfortable to sit still. My body feels like it needs to move. And that can be a common side effect of antipsychotics. It's actually quite common in antidepressants as well. So it's not just antipsychotics. This is the Parkinsonian gait. This is the shuffling gait that we're going to see that can come again. So when people walk back into my office, I'm observing how they're walking for signs of stiffness or imbalance. And you can often see it in the arms as well, but the asking someone to walk can be a sure way to look at signs of it. So let's see if this one will work.
This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then again, having difficulty starting in the marche petit pas.
Okay. This is an example of dystonia. This is in a kid. Pay attention to the jaw. This one's a little bit hard to hear, but you'll see them describing it. But the jaw like is tonically flexed and open. This is incredibly painful. This often is, you can give like IV or IM Benadryl in an emergency setting for. At home, we tell parents they can give Benadryl, but it's really acute onset. It's very painful. You can also see this occur with like neck twisting, or even the eyes can posture. But this is what dystonia of the jaw looks like.
Benadryl ready right now. I'm going to give that IV. We're actually going to do kind of a teaching video here on like a dystonic reaction. What's going on? Is that hurting? Yeah, so we're getting ready to give him some Benadryl, but he's having these episodes where his mouth opens up like this, and then he has to just manually, he closes the mouth himself. He likes the sucker, but every once in a while, then it opens, it spasms up, and then he has to manually close it. He just started on Adderall yesterday, and then he's also on Risperdal, you said? Risperdal. Okay, and he's been on those medications how long?
Risperdal has been on for 2 or 3 years. Adderall was brand new and just started yesterday.
Okay, all right. So maybe something about the combination of medications that kicked this off. So this happened to him one time before, you said?
Actually, 2 times.
2 times before.
Yeah, and you could hear in the background, this occurred, he was already on Risperdal for several years, and they actually added a stimulant medication, and that's a common trigger in combination with antipsychotic too for dystonia reaction. It can actually have a little higher rate with dose increase, initiation, or if you add an SSRI or stimulant or another medication that can worsen it. But this young man actually looks way more comfortable than most kids do when they have it, to be honest. It can be incredibly painful. And kids, especially with autism or developmental disabilities that may be on Risperdal for those reasons, can have a really hard time even telling you what's wrong. It can be so intense. So tardive dyskinesia is a wide range of movement symptoms. These tend to occur later in the course of care, but they really can occur at any dose at any time, but do have sort of some additive risk with recurrent uses. Typically, they do start out very mild. You may see some lip smacking, some subtle tongue movements. In fact, sometimes dentists in the dental office will be first to kind of notice that the tongue's moving during dental care, and the patient can't control it. It can then go to blinking or facial grimacing. You can start having even more impaired symptoms. If the muscles of the throat become affected, you can start seeing problems actually with the breathing muscles, where people will feel like they're having trouble swallowing, and ultimately they may even struggle to speak. We do not have the greatest understanding of the pathology of tardive dyskinesia, but we have made advancements in some more treatment options for patients. This is more of a cartoon, but it's going to show you what some of the subtle things are. What I will ask you to look at is in some of these very subtle symptoms, especially in the face, I think it's incredibly challenging to distinguish between tics and tardive symptoms. And so see if you can notice some things.
Let's take a moment to explore a little known condition that affects hundreds of thousands of Americans. Tardive dyskinesia, or TD, can develop in people who've needed antipsychotics or other prescription medications to manage a serious mental illness, bipolar disorder, for example, or schizophrenia. TD is a neurological condition that causes repetitive involuntary movements. People may smack or pucker their lips, blink excessively, grimace, or twitch. TD can make it difficult to sleep, work, or exercise, and it can be a blow to patients' self-esteem. These symptoms can also attract stares and unwanted attention. For people with TD who already struggle with mental illness, the added stigma is hard to bear. Some people withdraw from family and friends. Others abandon their antipsychotic medication without consulting their healthcare provider. People living with TD need to understand their symptoms. They need to be empowered to seek treatment, and they need the support and understanding of their family, friends, and communities. Learn more about TD at movementdisorderspolicy.org and help raise awareness and reduce stigma using the hashtag.
So one of the things to be aware of with tardive dyskinesia, unlike tics that tend to peak about 10 or 11 and get better with time, tardive symptoms can get worse and they can often be irreversible. And so it's really important that people do acknowledge or realize what they are. It may warrant a change of medications, and now we have some medications designed to treat tardive dyskinesia, but it really can be quite impairing. In fact, this was the rate limiting step of the first generations, like Howdahl expressively, that the rapid numbers of people were developing tardive dyskinesia, and it was really impacting them. And so we have had some improvement, I think, from the change to more second generation options in regards to tardive dyskinesia, but it's really important that you don't take a watch and wait type of approach if something truly is tardive dyskinesia. And oftentimes that approach is making sure you understand what else might occur. Lots of times it's the medications that may cause tardive dyskinesia, but it's the addition of other medicines that could worsen it. So adding an antidepressant, or even you'll see like some of the anti-nausea medications may trigger some of the symptoms. Mood stabilizers can worsen it. Hydroxyzine can also worsen it. Or antihistamine medications, stimulants, tobacco products can worsen, or nicotine and tobacco products can worsen things. So you can have a lot of things that can augment it as well. And so it's important to recognize it quickly. You may need to stop the antipsychotic. You may need to change the antipsychotic. People that have tardive dyskinesia may need especially consideration of clozapine as another reason, because clozapine has been shown not to cause tardive dyskinesia compared to some of the other ones, but it's something not to miss. Neuroleptic malignant syndrome, we also talked about pretty quickly. It's incredibly rare, very hard to predict sometimes who it's going to occur in, and it's not specifically dose related, but it is life-threatening. So if you are seeing fever, unstable blood pressure, and an altered sense of consciousness, I immediately tell people to go to the emergency room for an assessment. The other movement conditions we talked about, even the dystonia does not usually have a fever or blood pressure instability associated with it. So if you see those two things, that really needs an emergent evaluation. All of these movement disorders that we talked about really can impact people differently, especially patients with developmental disabilities, autism. those that have neurocognitive insults like traumatic brain injuries or in utero exposure, or have an underlying sort of cognitive impairment or other illnesses that may impact the central nervous system, I guess is a good way to say it, can show more risk of a movement disorder. And so anyone that has something that affects their neurons can be impaired by and at higher risk. And interestingly, even females have a higher risk than males, but I do not have a good reason for that one specifically. It's only dystonia that seems to be a little higher risk in males compared to the other movement disorders. So we've talked about what the side effects can be. So how do we safely track and manage folks, whether they're 5 years old or they're 50 years old or 80 years old? We really do want to see some baseline lipid panel. This is your cholesterol and your blood sugar, and then ideally at 3 months, 6 months, and then at least yearly thereafter. In the state of West Virginia, if you have a child that goes through the medication monitoring system, you have to submit these labs to show that you're following them, just because of the risk of the metabolic syndrome. At every visit, you want to be taking vital signs and getting their weight monitored. As I said, the weight can go up quite quickly, and there are some strategies to mitigate weight gain. I don't want to get into that too much, but that's always a concern, especially in kids. There's some strategies to add metformin for kids that might really need a certain antipsychotic to manage that, and that's had some success and some evidence base up to about 50% from continuing to worsen. But when you gain the weight, it's very hard to lose it, so it's important that you catch it quickly. And then vital sign monitoring. Also, you typically check liver function, AST, and ALT, just because that's where most of these medications aren't managed. Often I get an EKG at baseline just to know if there's baseline arrhythmia issues. And I think sometimes the EKG is helpful for other medications as well. I don't particularly, there's not a lot of guidance about how often you should follow an EKG if they're asymptomatic. That exception might be something like Geodon or Haldol or clozapine, where more frequent monitoring might be indicated, but certainly a baseline just to make sure you're not worsening a condition. The movement things we talked about are important. The AIMS test is actually a test. It's a structured questionnaire, which is for the tardive symptoms. You have a patient sort of sit up in a chair and you observe whether they're having any twitching movements throughout their body. The Barnes scale is a metric for monitoring degree of restlessness or akathisia. I would often check people's arms to look for cod wheeling, and always watching their gait when they walked in the room could be helpful. Not all medications will affect prolactin, and there's not a lot of data to suggest you should regularly check prolactin, but if you are on a medication that has a high degree of dopamine blockade and you or you have a female patient that tells you they haven't had their period, it's not a bad idea to check prolactin levels, as that could be a reason for some of those symptoms. And if you have an older patient or a patient that already is struggling with weight, those are patients who should be more cautious of starting the antipsychotic on in the first place. And so these are metrics for adults to be aware of, that you may want to have a little more deeper choice at looking at what antipsychotic you pick if you see any elevations in blood pressure, blood sugar, triglycerides, or waist circumference at baseline. Here we're back to that table, and I'm gonna have to come out to see what it says. So this is sedation, orthostasis, EPS. This is must be anticholinergic effects on this table. This tells you what those barriers may be. And so if you have a patient that was exceptionally sensitive to an anticholinergic effect, thorazine is incredibly sedating, has lots of anticholinergic effects, can cause dizziness. and they experience that, you would probably want to pick a medication without that, especially even in elderly patients. You don't want a lot of this, that. Sometimes you may be looking for some sedation. Maybe you have a patient that's having horrible trouble sleeping on top of their psychosis. Maybe a little bit of sedation effect at nighttime would be a benefit. And so you can kind of use some of these charts, and the one that will be attached is a little bit easier to set, to sort of help guide some of the choices as you get into some of the second generation medicines. Some of them have lower rates of EPS than others. Some of them have lower effects on prolactin, and you can help tailor sort of the choice given the patient in front of you in terms of what their needs are. The other thing to be aware is, if you think it's a patient that might need a long-acting injectable, you could start with an oral equivalent of a medication that you could ultimately transition, can be effective too. Other things I just want to add, as many of you know, I'm a big tobacco treatment specialist. It's also important to realize that health behaviors can impact these medications. Many of these medications will increase the clearance of the antipsychotic if they're actively smoking, and either increase the level of it, or of certain medications, or it can lower the concentration of these. And so you might get less antipsychotic effects with cigarette smoking or tobacco use, and caffeine consumption can also cause some degree of impairment. So if you have patients that had stopped smoking and then started again and then experienced some breakthrough of psychosis, that may be part of the reason. And so I didn't go into that, but some of the antipsychotics do have levels you can check with it. Clozapine has some levels associated with it. You could potentially check. So if you do develop some movement abnormalities, you do have some treatments. Cogentin or benzotropine is sometimes used to treat dystonia, akathisia, and Parkinsonia features. This class of medicines, and you'll see Benadryl, which is available over the counter, can help with that dystonia, although it can also be given IM or IV. Propranolol can be actually pretty helpful for a sensation of akathisia. Propranolol is a beta blocker, and we have 2 new medications that can be used for tardive dyskinesia. The challenge with some of these medications from Cogentin and Benadryl is that they're very anticholinergic too. So you can have added side effects from anticholinergic blockades of some of these medications on top of treating extrapyramidals. And so especially for like dystonia, there's a lot of debate about how long you should leave Cogentin on board. And there have been lots of patients that had their Cogentin left on for years while on their antipsychotic, and it was questionable whether you need to do that. And then they had some long-standing impairments from the Cogentin. So it's a balance and something you have to constantly monitor. I will tell you, I do not have a lot of personal experience with these new tardive dyskinesia medicines. They've come out in the last 7 or 8 years, I believe. They're VMAT inhibitors that help block some of the monoamine oxidase production. I bet our pharmacists could tell us, I believe they're pretty expensive, but they represented the first actual treatment at really helping reverse some of the tardive symptoms. Before, it was really one of those things, if you didn't catch it early, there weren't really many treatments. And so this has opened up a lot more options for patients that may have persistent symptoms. All right, so we talked about the categories, talked about how antipsychotics can be used, and we've spent a lot of time talking about side effect monitoring because it is really important. And if you aren't a person doing the medications, please be mindful of what the patients are telling you as you monitor them, because sometimes they do not recognize these things as side effects, or they may not recognize that their gait changed or that they look more stiff, and they may need all of us to help point them out and alert people. So that is all I have today. I finished with plenty of time for questions this time. Do I have any questions in the chat? No, I do not. All right, anyone have any questions?
Thank you so much, Dr. Swagger. That was wonderful. You always do a great job. And yeah, do we have any questions? Such a difficult topic. I feel really bad for everybody that has to deal with some of those side effects and issues. Any comments at all?
Yes, I had success with my first attempt at videos. Yeah.
Yeah, I just wanted to say that I felt the videos were very helpful because I work primarily with kids. So I think I see some of your examples in kids, but I've never seen them in adults. So I think it's super helpful when people are talking about that to have a visual of it. So yeah.
I was just gonna add, you were talking about the injectables, and I just pulled up the preferred drug list for Medicaid. They do require clinical reviews for some of those, but we do have quite a bit of preferred. So the Maintena, the Aristada, pretty much all the Invega injectables, and then the Risperidol Consta are all preferred. So we would still need a clinical review, like asking why you're using them or why it's clinically appropriate at that time. But it's not like you would have to try some other medication in order to get that approved.
Awesome.
Thank you so much.
Do you guys have any idea how much the tardive dyskinesia medicines are? I know I think they're really expensive, but I've never actually asked, so I didn't know if you had any idea.
They are, and on our side, we a lot of times aren't privy to the rebate information that they actually get, but you can usually tell by the amount of questions that we ask in order to get approval, and it has a full page of criteria. So I'm sure it is only to be used in those clinical scenarios where it is absolutely appropriate.
All right. If there aren't any other comments or questions, and thank you so much, everyone. Our next time we'll meet will be May 17th and building a reflective capacity, and Amanda Newhouse will be doing that. And other than that, we hope you guys have a really great next couple weeks.